Hi, good afternoon, everyone, and thanks for coming out to the PEDTalks event this afternoon. My name is Jason Thorne. I'm the General Manager of Planning and Economic Development. That's the PED of PEDTalks. And this is a dialogue series that the department started about a year and a half ago. And the intent is really to have a forum where both city staff and people from the community can come together and talk about issues that affect our city and issues that affect city building. So we've had, I believe, 3 or 4 of these events. We tried. Councillor Pearson knows. I should say hello to Councillor Pearson, who has been to every one of the PEDTalks so far. Thank you, Councillor Pearson. We're trying to do about 3 of these a year, again, to explore different issues that are important in the city. And the topic today, I hope, will be of great interest. It's one that's of a lot of interest to me, looking at that intersection of how we build and design our cities and the kinds of public health outcomes we have in our residents. It's something that we spend a lot of time working on, both within my department and within public health, trying to look at where those interactions and connections are. And so this is actually the first PEDTalks that's actually co-hosted between 2 departments. So it's co-hosted by Planning and Economic Development as well as Public Health. And I do want to thank Alan, who I'll introduce in a moment, as well as Dr. Richardson for helping to sort of pull together this program this evening, or this afternoon. I also want to thank Anne Lemaines, who does all of the organizing for these events and putting the agenda together. And I want to thank Joey Coleman as well, who's videotaping so that those who can't be here can watch later on from the comfort of their own home. And Joey, can you shout out where they'll be able to view this? Thepublicrecord.ca. Or just follow him on Twitter. So thanks again for coming out this afternoon. Our agenda will go until about 6 o'clock. We usually wrap up a little bit before 6 o'clock. We're going to hear from 2 speakers. And I think what I'd like to do is have both speakers present. We have someone from outside the community and someone from inside the community, because we thought it's good to get both perspectives. And then we'll call both speakers back up, and we'll have some opportunity for Q&A as well as from comments from people who are here this afternoon. So unless I have missed anything, that's good? Okay, so I'm going to ask Ellen to come forward from Public Health, talk a little bit about some of the work that they do, and ask her to introduce our speakers for this afternoon.
Thank you, Jason. It's a real pleasure to be here. We have been meeting informally with Planning and EcDev and Public Health for about a year, trying to identify some collaborative opportunities, and this is a great honor to be here in partnership today. As Jason mentioned today, the PEDTalks today is about community design and its impact on health. And we recognize we have a big problem having engineered physical activity out of people's lives by building communities that are really reliant on cars. And the question you might ask is, why is public health here talking about planning? And public health is really interested in urban design and being part of this dialogue because health is largely influenced by determinants outside of the healthcare sector, such as the built environment, as well as other social and economic factors. The way we build, plan, develop, and maintain the built environment can significantly support or discourage healthy lifestyles. Many of us can reflect on the days of years ago walking to school was a normal activity. And now we've been working in Hamilton towards an active, safe, sustainable school transportation charter to actually bring the parties together to actually bring that back to a reality where children are walking or riding a bike to school. Public Health Services is focused on making Hamilton healthier by increasing physical activity opportunities, creating healthy food environments, improving community safety, air quality, addressing climate change, and also reducing exposure to ultraviolet radiation. If we aim to build and plan our communities so it's easier to be physically active and to have healthy access to food, for example, it'll be easier for people to make those healthier choices. We have an opportunity here in Hamilton to build upon our existing partnerships, such as those with Planning and EcDev, as well as McMaster Institute for Healthier Environments, who are speaking here today as well, and the synergy that's created by the partnerships and the diversity it brings. And to coordinate our actions, across our departments and sectors to contribute to the goal of the healthy city for all. So I now have the distinct pleasure to introduce our keynote speaker, who will highlight how working together across sectors is addressing the built environment, Gayle Bursey. In her current role as director in the finance department, Gayle is leading the development of the Region of Peel's growth management strategy, which brings together experts from planning, engineering, and finance disciplines across 4 municipalities. Prior to this, Gayle served as the acting commissioner of the Human Services Department at the Region of Peel. Here, she led over 700 staff in the delivery of affordable housing, social assistance, childcare subsidy, and community programs. Before joining Human Services, Gayle led the transformation of the Poverty and Asset Management Division at the Region of Peel and the development of land use, transportation, and health policy, such as active design guidelines for affordable housing and design guidelines for bike networks. She was also Director of Chronic Disease and Injury Prevention in Public Health for 12 years. Gayle holds a master's degree in environmental studies, a Bachelor of Science, and is a registered dietitian. She has recently completed a fellowship on policy development with the Canadian Foundation for Healthcare Improvement and has served as a member of Public Health Ontario's Strategic Planning Committee and is past chair of the Pan-Canadian Health Promotion Network. Please join me in welcoming Gayle up to the podium.
Well, good afternoon, Hamilton. A little bit. It's a sunny day in the spring. I want to let you know that when I think of Hamilton, I think of you very fondly because my son is here being physically active. It has nothing to do with his mother, because in the old tradition where the cobbler's children go shoeless, the public health professionals' children eat junk food with gay abandon and are not physically active. So I thank you, those of you, I think there's some folks who would have been influential in the bike lane development that you have now in this city, because my son has not ridden a bike since he rode a tricycle, but he rides a bike to McMaster because he can get a better seat in the lecture halls. So it has nothing to do, and it's safe. He's not particularly comfortable biking, but he can go on your protected bike lanes, get to school, and get the better chair in the lecture hall. So the messages I have there at the end include design changes behavior. So thank you, Hamilton, for changing my son's behavior. So back to the script. I'm here to talk to you about a report that Nin Tran, an Associate Medical Officer of Health here at the city, asked me to talk to you about. And it was a report that I did with these 4 gentlemen, I should say, just before the provincial elections. We started in 2013 and we got it out in the spring of 2014. And the reason that we did this report, well, the reason I did this report is at the time I was Director for Chronic Disease, so the diseases that take a long time to kill you. So unlike our friends in communicable disease and public health, we get all the profile, H1N1, people understand what you do. We try and prevent chronic disease in the division I was in. So it's heart disease, cancer, diabetes. And it's tough to create excitement around those diseases, in part because of the slow onset, because they just aren't as dramatic as communicable diseases, and we're not as well known for them, but they cost a fortune in the healthcare system. So I was sitting with this problem, and having had the experiences with my son where nagging does not work, I knew that telling people to change their activity level and to eat differently was just not going to work in and of itself. And knowing that design does change behavior, I wanted a way to speak about what I'm going to call in this presentation the big problem. And I wanted to talk about how planners, engineers, and public health could work together to start to put a dent in the big problem. And I needed, in a sense, poster children, the doctors, to get some media attention on this issue. So I'm going to tell you in this presentation how we developed this report, and then I'm going to give you some examples of policy changes that we've done, that have been done in New York City and across the GTHA, to show you that we are making a dent in this problem, but we still have lots of work to do. So hopefully that's the presentation that Nin wanted and what you thought you came to hear today. And then we're going to have some questions. So essentially, the big problem that we have is that in the Greater Toronto-Hamilton area, we're going to add 2.2 million people in the next 20 years, and all their cars. So they're not going to fit. To visualize what that looks like, I'd asked my admin to find a picture of Montreal, and she knows I like the Boston Bruins, so this is revenge of the admin assistant, because it's with great pain that when I saw this, I said, what is that? Have you sent these already? I can't stand Montreal, but there's the Montreal Canadian flag. So we have a little bit of a sense of humor in our office. So if you took Montreal and Vancouver and dropped them into the GTHA, you would have 2.2 million people. So it's obviously going to have an impact on traffic congestion. And in the report, we estimate we would see a change in commutes from about 82 minutes to 109 minutes. Obviously, it's going to have an effect on air pollution as well. So we estimated 854 premature deaths related to air pollution if we add these folks, or sorry, I should say when we add these folks. But this is the really big problem. When we look at the provincial pie in several provinces across Canada, so all the money that's collected from all the taxpayers, and we take out the portion that pays for health, the other half of the pie is all that's left for everything else. Justice, roads, education, the environment. When you think of all the other things you have to pay for, you can see how health is eating the budget. So we can't keep doing this. The case I want to make in the next half of the presentation is why we have to sound this alarm and do something together as planners and engineers and health professionals, and why we need to help people draw the connection between that healthcare pie and the way councillors in cities across Ontario make decisions about planning. I don't think that councillors think, as they look at individual development application policy, that they are causing diabetes or preventing it, but they are. So in the report, we looked at community design elements. Those of you who are planners will understand the major elements we're concerned with, street connectivity being one of them, but we also look at proximity to service and mixed use. And we show how they are connected with the ability for us to run effective transit. And then transit is connected to the incidence of diabetes, because inactivity or not being able to commute by public transit or by active transportation, we show in the report is contributing to high rates of diabetes. It's helpful when we think about these kinds of issues to look back in time. And when we look back, public health and planning and engineers did work together quite functionally, almost before they became distinct disciplines. When we look at this slide here, we see in Chicago things that we take for granted now. Infrastructure, water and sewers, or water and sewer underground. So that shows you that in the early 1900s, we were working together. We kind of drifted apart. And even now, I mean, this slide I have to credit Dr. Mowat, my previous medical officer of health with, but I see it turning up all over where this talk is given. And it shows that even when we give thought to creating a way for people to be active, we're human. We will always take the easier route. So we actually have to make it the default decision. And that's why this discussion is really about creating policy using health data. So as I was moaning earlier, folks that work in infectious diseases do have it a little bit easier, because infectious disease, the things that people used to have a problem with in their built environment before underground sewers were cholera, typhoid, et cetera. So they cause death quickly, and there's no coming back. Unlike chronic diseases, which are our challenge now, where death, frankly, is slower. And if you've known anybody that's had diabetes, it's just horrendous how it affects your ability to function. But the cost is huge. So we do have a bit of a brand problem with chronic disease, using it as a way to increase better policy for planning. But one of the stories that I like to tell that's so effective is the story of the Broad Street Pump. So if public health people, have you already heard the story, public health people? But it's worth telling again, because it's one of our legends, and we don't have that many. So, and what I like about this is that it's one of the first times when there was cross-disciplinary work happening, you know, that we know about, other than the Romans, perhaps. So in London, England, in the 1850s, there was a cholera epidemic, and it was happening when you have to realize that you can never judge history with your modern mind. People didn't understand why there was death related to cholera, or even what was happening. People were just dying. So a thoughtful man, John Snow, decided to, observed, like a scientist, he observed and he saw that in certain areas of the city people were dying. So he, for whatever reason, decided that the link might be the water because that was a commonality among these people. So he took the handle off the pump. So it's a bit of a broad policy intervention, but it was a different time. So what he then observed is that people did not continue to get sick. So he reasoned that it was the water that was transferring the disease, and he then began the very hard and laborious process of convincing the city leaders that they needed to put the pipes underground. He had to convince them that they needed infrastructure, and what he took with him were engineers to explain how it would happen. So if you're working in this issue or you're ever feeling discouraged about your life in public service, think about the conversations that he would have had to have along with another hero of public health, Edwin Chadwick, the fellow that has a very bad comb over if you Google him. So he and John Snow convinced the city leaders in London that they needed to do something about the fact that the city was awash in sewers and that they needed to put infrastructure in. So you can imagine the discussion. So these engineers say, we need to rip up the roads, we need to put some pipes in, we're going to put sewers underground. Well, how many roads? All of them. So it doesn't seem so discouraging to try and put a few bike lanes in or the LRT or the things that we're trying to do now, because that was a time when people did not understand why the masses should have tax dollars spent on them or why there was any connection in terms of the spread of disease through the water. So I take heart in that, and I also think there's an important lesson for any of us in policy development that you need to work across disciplines, and that any progressive idea that's ever occurred in a civic arena has come because someone observed, had an idea, and then tested it. So it gives me comfort when we're working now with the struggles that we have, that if someone could convince the City of London to put pipes under all the streets, we can certainly get a few bike lanes inserted into our cities. So the next chunk of the presentation, I want to tell you about how big the problem is. I'm not going to spend a lot of time on it. You can Google the report or look on the Regent Peel website or Hamilton's. This is what it looks like. There's a short version, and it gives you a lot of detail about how we're building the case, because we wanted people to be able to reference this report when they were in a tough situation with the Ontario Municipal Board or with a council that was really struggling with some decisions. So we put the best science we could into showing that physical inactivity costs the GTA about $4 billion a year. This is because we looked at some specific diseases. We have an increase in obesity, which is obviously related to physical inactivity, and an increase in diabetes. We looked to see roughly how many new cases of diabetes we would see, and we found that it would be about 1.2 million people by 2027 would have diabetes in the GTHA. So if that was a communicable disease, or if that was asbestos and children in schools, we would be doing something. So we needed to have some good science behind the numbers that showed what type of disease rates we're looking at. I'll a little bit later tell you some more about the methodology, but we also wanted to explain that not only is it difficult to make a case for these non-communicable diseases, diabetes and heart disease, but it's also difficult for people to understand how that little bit of activity change that is so subtle and that we've all experienced over the last 50 years has really made a difference to our health. So if you have children, you've been around children, you'll know that their lives circulate around these objects and not pass the ball. And it's a policy issue for us because we are so concerned about children's safety. In my neighborhood, we have a sign in our park with a big circle and a line through it that says no ball playing. And the school that my children went to, they couldn't throw snowballs, they couldn't have baseball bats, it was just endless. They couldn't ride their bikes on the school property. So then they didn't ride their bikes because they get them impounded. So we really have to think carefully about the policy decisions we make related to activity, because even though it doesn't seem like a big deal, those decisions were all made for concern around child's safety. But when we add up all those little bits of time, we really see a change in the amount of activity that we're all getting. And it all adds up, because the great thing about activity is you don't have to get an awful lot of it. You can get small little 5 and 10 minute increments. But if you lose that on a regular basis, like a child going to school, you really do see an impact because as the most recent research on physical activity shows, it's not going to the gym 2 or 3 times a week, which is a bit upsetting if you manage to haul yourself there. You can still be at a fairly serious risk for heart disease and diabetes because it's the blood sugar and blood lipids on a daily basis and your body not moving that really affects your ability to develop or not develop heart disease. So I put this slide up because I wanted to tell the story about the Milton School Board who was courageous enough to say, no busing policy, you can walk to school. So it's a forced march. It's the only one that I know of that's had that kind of courage. So I mention them because I think it's just such an obvious thing to make it non-negotiable. In the region where I live in Peel, we had about 30,000 new individuals a year, many of whom in their country of origin would walk and bike to school, and it's a completely normal activity to be in public transit. But we have kiss and rides, so they drive their children to school because they think in Canada you drive your child to school. So it looks like a zoo every day at I think it's like 250 schools where parents come, drop their kids off and leave, and they repeat the whole process at the end of the day. So my summary point in this slide is that we don't realize how powerful physical activity is, and then through policy mechanisms, we pull it out of people's lives. Or as we're hearing when people give this presentation, they often say we engineer it out of their lives. And it's those small little bits of activity, even a 5-minute walk to school, that make a huge difference in the rates of diabetes that we see in the individual lives who are being affected. So in the report, again, to give this some power, we estimated that the risk of death would be decreased by 22% if you just got half an hour, 29 minutes a day of physical activity. All in little bits. It doesn't have to be a solid 30 minutes. So that's a pretty powerful way of understanding what we have done by taking physical activity out of our lives. This slide shows that it's not just the inactivity, it's also air quality. So there's much more in the report on that, but I just wanted to mention it because we forget that traffic emissions do actually amount to premature death. About 1,000 premature deaths per year, we estimated in the report. I was mentioning earlier why it's a policy issue, and that's because there's so much policy that exists now that is a disincentive. So when I was director for chronic disease and I went on a secondment to purely work on healthy built environment work, and I was working on a policy fellowship, and one of the themes of the policy course was that you need to start at home. So I thought, I better bike to work, I better figure this out. So I got Sorels and I got a good winter coat, because I realized you're exposed to the elements. So you forget that when you're always driving to work. And the first problem I had is that you can't cross. There's 4 or 5 400 series highways in Peel. You can't cross them because of the Highway Traffic Act. You have to yield. Well, in the morning, there's no yielding. So I'd be on the corner waiting, trying to get across. And the only way I ever managed to be able to actually walk the talk and bike to work was putting my bike in the back of a van, driving to a big box mall, leaving it there for the day, taking the bike out and driving illegally. I know, but what else was I going to do? Driving illegally on the sidewalk. But I never got arrested because there were never any pedestrians on the sidewalk because it's Peel. We're massive suburban sprawl. But nobody's going to go to those kind of heroic efforts unless they're supposed to be the director for built environment. So the point is we got to make it a lot easier for people because they can't bike to work in this. The other thing I tried to do was to figure out how to get my kids to bike to school. And I won't get into where exactly this is, but say this is some region in Ontario, and they're trying to put in bike lanes, but the school is on the right-hand side, so on the other side of the 40 sign is the school. And the bike lane is the white lines, the pavement. But between the bike lane and the curb is the school bus, like 7 or 8 of them. So your 8-year-old has to be on the bike lane beside the bus, in between 2 buses to get to school. So nobody's going to feel safe doing that. So this isn't cutting it, folks. We have to have good intent and good design. And one of the ways that I've found it's helpful to not make enemies out of people who are trying their best, but really drive this message home is to put leaders in the position of the citizens. So at one point I put some counselors on bikes and had them have the experience of being on painted bike lanes to help them understand why it's just not enough in many of our streets, especially our regional arterial roads. You need protected bike lanes. And the champions of this are in Vancouver and Montreal. So if you're ever doing work on this and you want a very good and someone who's been through all the tough times of bike lane development, Jerry Dobrowolny is a director for transportation in Vancouver. At one point, so it was the stories on top of that. He was telling me about how he would put counselors onto bikes and have them experience the actual bike lanes. And then he did some very good research on, once he did get agreement to put in buffered bike lanes with the protected ones like you have here for my son, he showed how high the increase in usage was among women and children in particular, because we just don't feel safe biking without them. So that's the end of making the case for the relationship to inactivity. I now want to talk about when we were developing the report, how we had to use the existing reports that existed. At the time, Metrolink's Big Move report was just getting some uptake, and we were talking a little bit about transit, but this is 2013, so the discussion that's going on now about public transit was not happening. But we wanted to support Metrolink's implementation of the Big Move, so we used that in the report to do the modeling and the forecasting. And we also obviously looked at the places to grow and other provincial plans that push intensification in transit. And notwithstanding that now, just this week, we had the release of the new Places to Grow amendments that are going to be challenging for us. There's going to be a transition period, but we're thrilled that since we started this report, we're seeing a really different discussion in the media about the need for public transit as a public good. But when we wrote this report, I can remember we put together the recommendations. We wanted something really crisp, and we came up with a recommendation that said, fund public transit, it's a public health good. It was completely radical. There were folks that we were working with who said, we can't say that. We're public health. How could we say that? But it is a public health good. We just finished proving it in the science. So I think one of the themes I would leave you with is that we need to have courage, and we need to be like Spock and go where public health hasn't gone before, or go with planners and engineers where none of us have gone before, because it doesn't sound that radical now, but at the end of 2013, that was a radical thing to say, that public transit is a public health good. The report, as I mentioned, identifies some benefits related to traffic congestion and goods movement, but really the key message we wanted to bring forward was that we had done our homework and we had assessed the relationship between health and the built environment. So just for a couple slides, I'm going to give you the methodology for those who I heard were interested in it, and then move on to some policy change examples. So no good self-respecting public health professional would be without their data. We're absolute maniacs for data. We have these epidemiologists, if there's any in the crowd, who are pure health data gurus. And we looked at the data, and we also love to look back in the scientific literature and see what's been done before. We're scientists at heart. So we did that. We also looked at existing projections and the tools that were available to assess the baseline of current active transportation activity. And then, for those of you who are interested, the tools that we looked at were the health economic assessment tools, a HEAT tool from the World Health Organization, the diabetes population risk tool, which Dr. Rosella from Public Health Ontario and her colleagues use, and Toronto Public Health had a burden of illness air pollution tool that we also used. Then, I won't go into this. The point of this is showing that there was a whole decision tree that we went through in order to make the relationship between the boxes on the left-hand side, public and active transportation, because public transportation is active because you walk back and forth from the bus stop. Active transportation meaning using personal power, cycling or rollerblading or however you're moving to get to wherever you're going. We looked at physical activity and traffic emissions. Then we looked at deaths and rates of diabetes. And then we looked at the economic relationship between increasing and decreasing the level of activity and the potential diseases that we'd see. Even with that, we ended up with pretty strong numbers, but I want to tell you that these are really conservative numbers. So all the white boxes are things we didn't consider, and we left for the next group of researchers to look at, because we really wanted to meet the May 2014 election post, that we knew the election was going to be called sometime in the spring, and we really wanted to make sure that we had this material ready. I don't think the Crombie panel had been set up yet, but we definitely wanted to be in on that discussion, and I'm really proud that some of our work is represented in that document. So these are really conservative estimates, but even at that, we saw that we could have, if we implemented the big move, an increase in public transit use, an increase in active transportation routes to work and school. Again, the reason that's so important is that even if you're physically active by going to the gym, but you do not have daily activities such as commuting back and forth to work, you're still at risk for heart disease or diabetes. And an increase in short trips. That was the most powerful way to influence people's activity. It wasn't the big drive, it was the little one to pick up children from the library, to pick up kids from, take them to hockey. Those short trips really add up and are quite powerful. And then finally, traffic emissions, we saw them go down. In terms of the actual benefits, again, you can look in detail in the report, but we were happy to have numbers that were significant enough to get media attention. So we predicted if we implemented the big move, we could prevent 184 deaths a year, that we could see about 1,000 fewer cases of diabetes, and that we would see fewer hospitalizations at about 90 a year. So this is an example of one of the many city halls around the province that make decisions that, as I said, related to planning may not seem like decisions that promote or decrease the risk for diabetes, but they do. So what I want to say before I go into the examples of policy changes, that I think public health is a bit of a best kept secret in some parts of the country, not just the province, and that we are coming of age in terms of working really collaboratively again with planning and engineering. We did it back during the sanitation movement. We drifted apart. And the kind of things that we bring are, you know, as my father used to say, if you come late to a party, it's all right if you bring something. So what we bring is when we be showing up at dinner time at people's houses. But the point is we bring data that we want to share to make a business case, because we realize how hard it is to get the attention of decision makers. We feel like we're the poor cousins when it comes to health, because most of what you hear about in the media related to health is clinical. It's that the big slice of the provincial budget is really the clinical disease prevention. Public health, I think we're like a bug on the windshield. We're less than 1% of that big budget. But we do have a role in working towards prevention of disease with partners such as planning and engineering. So we're useful in that we can bring data. We're useful in that we got 40 media hits from this report that we didn't expect to get that much, and we got good quality media because I think it was so novel to see 4 medical officers of health coming together and saying planning is an issue, you need to listen. And if you want us to prevent disease, you need to fund public transit. You need to support planning and transportation to be an automatic discussion at City Council, not something that is always susceptible to market forces and political forces. You need to design the way those decisions are made differently. And finally, I think that we are useful when the going gets tough. So I think if there is an OMB challenge related to a planning decision where there is a health impact, I think we should be bringing medical health officers or other health professionals to OMB to be an expert witness and to help planning defend decisions that they've made. So that's a summary for the first part of the presentation. That when I met Jim Dunn years ago, I remember saying, how do we get to know researchers better? And he said, well, take researchers to lunch. So I'd say, take a public health person to lunch and talk about how they can help you in your work. So those are the 3 recommendations that we came up with. They seem so normal now, but they really didn't in 2013. And they actually were quite radical for some of the folks that we were working with. So I'm just going to move into a series of fairly quick slides on the policy changes that I've seen affected since we started this work, and then we can have a discussion, or actually I'm going to give you a second speaker. So first, the Healthy Development Index. So this came about because I remember sending a report to council, And you know how sometimes when you send reports to council, I'm speaking to people here that send reports to their council, and sorry for the councillor that's here, sometimes you put in more than you think you're going to get in case something gets knocked out. So we put in a series of recommendations, one of which was that public health staff could comment on the development applications. And I remember, we were debating which ones should we, and we said, well, let's put them all, let's say we'll comment on all of them. And oddly enough, the council that day, they really bought into the concept of health working more strongly with planning, and they said, yes, do that. So we thought we would go into planning or public health literature and we'd find some kind of an assessment tool, and we didn't. We ended up having to invent one, and that's how I first started working with Dr. Jim Dunn and some of the other colleagues that are here to develop this assessment tool, which those of you who are planners will recognize the terms at the bottom. What we were showing was the relationship between those planning elements, density, proximity to service, et cetera, and physical activity. And just to give you a taste of what it looks like, this is a sample of the quantifiable measures that are there and can be used to assess a development application. Then we started to move the use of this tool into local policy. So we are a two-tier municipality, so at the regional level, we have the index within our official plan as a tool that can be applied, so may be applied, and within the 3 municipalities, we've moved from may to shall. The reason in both cases we started out with may is not because we were feeling timid and didn't want to say shall, it's because we wanted to test it and we wanted to work all the bugs out, and we wanted to give the development community the opportunity to see what we were talking about and to have their application assessed and sent back with suggestions of areas for improvement, and then work with them to understand how, if they made a change to the amount of parking, for example, or put it in the rear, how that was going to affect their business mix and potentially cost them money, and to talk with them about what they could do to achieve the same ends that we wanted through different measures. So we are now at the stage, and I won't go into detail on these, but they just give you a flavor for the language. We're now at the stage where all 3 municipalities, Brampton, Caledon, and Mississauga, have the index as part of a decision-making that they do within the review of applications. And Brampton was an interesting situation for us in that they wanted to use sustainability or the environment as the platform. And I think that's smart policy making, and that it doesn't have to be health, it doesn't have to be good city building. What it has to be, whatever you use, is something that has meaning to that local set of decision makers. And for Brampton, sustainability was the key. And I think there's lots of synergies between among sustainability, health, and active and public transportation. So we used the sustainability guidelines. So it doesn't say the health index. The index is embedded in as a decision-making tool in these sustainability guidelines. And I can remember the day this went to council, we had Dr. Mowat come and speak to the councillors because there was some whether this was going to pass or not, and what were the councillors going to say, and was it going to, give the development industry a lot of fear. So we had him speak first, and he did a lovely job of inspiring and creating the aspirational benefit for the councillors. So I can remember he put up a picture of a cathedral. If anybody who knows him knows how much he loves architecture. So he put up a picture of a cathedral in Europe and said, the people that voted to put this cathedral together knew they wouldn't even live to see it built. And that's the opportunity you have this morning, ladies and gentlemen. So I think another component to working with public health is that we can give you a different voice to get through to decision makers. And I do think that anyone who gets into public service, doesn't come in because they want to hear the public concerns on all the issues they're going to hear. They get in because they want to do something effective. They want to see a better world. So it was helpful to have Dr. Mowat bring that kind of inspiration to that group. This one I put in because we're in Hamilton, and we'd be happier for you about your LRT if we weren't so unhappy about the fact that we don't have one going up here, Ontario into Brampton. So good on you, Hamilton, and we look forward to hearing more about it as it unfolds. But we don't have one. We have our LRT is going to go to the edge of Brampton through Mississauga, and someday it'll continue on. But the policy issue here that we have to be patient with is that transit is experienced as a regional or cross-provincial experience. Citizens don't say, I'm in one city, I'm in another, especially within the GTHA. So it's a bit odd that we have the decision-making power sitting right at a city level and not the ability to think across regions the way people travel. So That one's, sorry, for you, Hamilton has another picture of it. The next thing I want to talk about is, and I just brought one copy of this, is work that we did, this is purely with the engineers this time, to develop this document. So we realized that in Peel we had a small number of classifications of roads. So we had big, really big, and really, really big. So that's not enough, and it's not fine grained enough to create, for the municipalities or even our planners and engineers, to create enough intersections, is what this shows, or to be able to create what planners call complete walkable communities. You need more fine-grained tools in the toolkit. And the reason I took this picture is that when I used to drive to work in South Brampton, I would see these kids crossing. This is what planners would call the mid-block crossing, but it's chicken. The high school students come and they'll stand in that little section there and teeter on their backpacks because the cars are whizzing by. So clearly there needs to be a better way to cross, and they're teenagers. They're not going to walk the long distance to the end of the block. So we created a few more categories of roads, and that's what this road characterization study shows. And then with each of these types of roads, we created a cross-section, so planners and engineers literally work together in tabletop exercise designing what the intersection would look like. So this is just to demonstrate that no matter where you start with the policy changes, you need to follow all the way down the process to whoever's making the decisions in both planning and engineering camps. And this is work we were doing with the engineers. And then in terms of a policy issue, we had to sell it because you need to be able to demonstrate what the benefit is when you're taking something like this to council for approval. So for some businesses, they were happy to not have to have parking, allow parking in front of their business. They could put it in the back, so that's what this one shows. Oops. Oh, somebody has done something fancy for me. This is a revenge of the admins again. Okay, so now moving on to when I was in human services, is what we call it at Peel. It's the social services department. I wanted to, as I had learned in this policy fellowship, I wanted to make sure that we had maxed out our own policies in terms of demonstrating a healthy built environment. And it's also a great way to learn what's not so easy about some of these bright ideas that we come up with in this topic. So we took a report to council. We also had a group of councillors on a committee to advise us. And in our region, council is our Board of Health. We don't have a separate standing committee, so it can be tough sometimes to get airtime with our councillors. So we created a committee, and I'll show you a little bit later some pictures of New York. We also took them to New York to show them how, at the time, Mayor Bloomberg was working across planning, public health, and engineering departments to create healthier, walkable cities. So that was quite powerful, and then we brought forward a resolution, this is what it ended up being, that we would work within our organization to increase active design, is what we called it, for all of the buildings. So for our social housing buildings, for the regional buildings that regional staff are in, as well as in the ambulance stations. And we created these active design guidelines that now go out with the RFPs for all regional work. So for building a new affordable housing building, we have adjusted some existing buildings, and then we've gotten RFPs for design of new buildings. And it's gone. Uh-oh, there we go. So this is the building that the guidelines are based on. It's a building in New York City that is a social housing building, but of course it doesn't look like it, and it has exercise equipment in the back part of the building. So we took some counselors to actually show them this building and to help them understand how, given that for us in health, the folks in affordable housing make up a really high proportion of the rates of disease that we're trying to prevent. So it's good public, it's a good public policy activity to make sure we design these buildings so people can use the stairs and that they can be active. What I found really interesting on my theme that design changes behavior is how in New York, with a relatively inexpensive approach, they created a building that does not look like social housing. So it's just so New York, this interesting design, and then they repeated it in the stairwells. You know, very inexpensive kind of art, but very effective looking. And then we brought that here we brought that here and created an award program with Brampton and Mississauga. And you can see in the bottom there, social housing that has the garages on the back of the townhouses, and that was a big innovation that we had to work through even after we had the social design guidelines or the active design guidelines in social housing in our RFP, and we had a winner for the RFP. We still had to work with that vendor to help them understand what we meant by active design. It wasn't some token little play structure, that we needed the garages on the back of the townhouses, and we needed them to face each other so that the space in between was not individual to each member of that series of townhouses, but it was communal. So that's space there where there's small garden plots that were individual. People could sign up for them, and where there's a play area for children. And then, you know, a good public policy approach is to reward people when they do what you need them to do, so that's why they were award winners. This again shows how we created within affordable housing options for activity right on site, and that bike room there was a source of great debate because it was felt that it was a frill and a luxury, nobody would ever fill it, and then, you know, instantly it was overflowing. There's not enough room for the amount of bikes that are needed, and that's why you can see, and that's what, in that you can see how you do have to, like I was saying earlier, have an idea and try it, and you do have to fight a bit of inertia because, you know, even I started to doubt, well, maybe it will be wasted and it'll be an embarrassment that we have the space, but it didn't happen that way. People understood what their opportunity was because they could ride their bikes right outside of the affordable housing. So another venue that we moved into was the design of engineering standards, and the story I'll tell connected to this is that those are the directors for transportation and planning at the region and myself when we got it all done. But the way this work started was that I was asking transportation what the challenges were related to bike lane development. And one of the things that they identified was that the Transportation Association of Canada that sets the guidelines that they use to design bike lanes. So how wide is it? What's the buffer between the parking and the bike lane? How do you get a bike lane to intersect with transit riders who are alighting, and everything related to getting around a bus shelter? Who knew it was a completely complicated issue to get a bike lane to go around a bus shelter? So they said there's just not good guidance on it, and we're concerned we have to sign off legally on all of these designs, and we just don't feel comfortable that it's safe. So I asked them, well, who makes these guidelines, and do they ever get reviewed? Yes, they're being reviewed. They're geometric design guidelines, first time since '99, so I was confident that they would need an update related to bike and pedestrian use. But the people that are working in this area within the region of Peel are just so busy because we add so many people that they can't keep up to the regular demand for their work. So they asked me to sit on the committee. So I went to these meetings with engineers from across Canada, and at the beginning there wasn't even an interest in having a chapter on bike lane development or pedestrian use development. It's just not something that is seen as a burning issue. But clearly, you know, even this would have been pre-2013. Clearly it has become an issue. You know, we see funding now. But it is an issue in the US. So we were able to develop this document that shows how you can create all these design standards and be able to sign off confidently. It's based on work that was done in Denmark and the Netherlands and in other cities, especially American cities, such as Boston, Chicago, New York, where they're tackling the bike lane issue in a huge way and are able to offer Canadian engineers some comfort in how to do this kind of designing. The last few slides I'm going to show you are just parts of New York City that we took these counselors to inspire them, and also to deal with the, yeah, but we can't do it here because of that problem. So often we will hear there's not enough space, or it's just, we can't imagine how you're ever going to fit it in, given everything else we have to do. So what I like about this is just space between two buildings. But, you know, leave it to New Yorkers to turn it into a dog park. So, and it's not very big, as you can see, but it's well designed, and you can see people are using it. And they even have added the fake hydrants for the male dogs. So I think that same theme comes back to me again and again in this work, that you need to have the ability to step back and think and let ideas float to the top of your mind, and then you need to try them, because you could have said there wasn't enough space. One of the things that struck me when we had the folks from New York, so their Commissioner of Planning and Transportation and some of their councillors come up to Peel, they looked on, if you know Peel at all, here in Ontario and Steeles, and said, you've got all kinds of room. What's the matter with you people? You could put a bike lane here, and you could do all of these amazing things. And we had them look at our schools, and they just about fell over. They were so happy to see how much space there was. So, you know, they look at this space, and we look at this and might think, well, what are we going to do? And they look at it, and this is what they see. So yeah, that theme of good design, ability to imagine and create interesting ideas, it's quite powerful. And I did find in this work, and I would recommend that in general, that it's really good to look to other communities where they have done it and bring those profits from another land to your decision makers so that they can imagine a different reality. So from that space that I just showed you in New York, this is what we've done in Peel. So this is heritage signs, because we had a strong historical group that wanted to be involved in this work. This is a school, and when we asked the teachers what they wanted something to help with discipline or management. So there's a section there to cool off and a section to think and talk it out. So they wanted something to help with character development and problem solving. So again, a creative way to get public spaces to really work for all the players that are using them. So this is one in schools. We've started to do this within the Region of Peel workplaces as well, create active design. When we asked the staff what they wanted, they said they wanted to walk, they wanted it to be timed, and they wanted it to be attractive. So the dots that are circled there are two different kind of walks. So if you only have 10 minutes, you take the pink ones, all you have to do is follow the dots, and you're done. You get a 10-minute walk. And the bigger ones are blue, and you get your lunch hour, 20-minute walk. And it's been amazing how powerful that's been for people because it idiot-proofs it. It makes it automatic. It's not like the escalator and the stairs where you have to make a choice. It's just very straightforward to use. Another thing they said is that the stairwells were ugly. And we didn't have a lot of money to make changes to the stairwells. It is expensive to retrofit, but we found these door wraps. And people kept asking us where we got this, what the supplier's name was, because they wanted to put them, in their own personal space. But amazingly enough, just using the door wraps, we did see an increase in stair use of about 40%. And that's around 400 trips. We have 3,000-ish staff. And then we were able to calculate how it increased, or decreased the use of the elevator. And we actually have a noticeable decrease in our electricity bill for the region related to elevator not use. So wrapping up now, in terms of next steps, I think it's really important in this work to pre-post evaluate. It's never as good as you want it to be, but it's important to do. When New York City did this, they saw, as you can see here, an incredible, almost 300% increase in cycler commuting. Vancouver's a good place to look for Canadian stats on this, where they've seen good increases as a result of bike lanes that they've put in. And then, it's tough to say that this is the work that they've done in New York has really been the cause of a change in obesity, but it certainly didn't make it worse because they have seen a decrease, especially among children. So in summary then, we have engineered physical activity out of people's lives. It was innocent enough. We thought we were doing a great thing, but we weren't. And we can't add those 2.2 million people to the GTHA in the same way as we added the last 2 million. They're just not going to fit, and it's not going to be a community we want to live in. So my key messages are that we are making progress. I think we need to not be discouraged about this issue. I think given my sample size 1 son, design changes behavior, and it's a lot more effective than parental nagging. I think a planning decision is a health decision. It doesn't feel like it, we don't think it is, but in the report we prove it is. And it has been since the turn of the century when we were worried about the sanitation movement. I also think we need to take heart, because I think if Edwin Chadwick could convince the City of London founding fathers, the council at the time, to rip up every single street and put sewers in, then surely to goodness we can put a few bike lanes in. And then, whoops, just hand it to a pro. Just get out of the way and nobody will get hurt. That's how I feel about administrative people. Thank you. So I have one last slide to show you. So this is New York City again. I wanted to end on this because I think it's an optimistic way to look at this issue. So this is in New York City where they took a lane of traffic out and they were trying to create space that people would want to be in. And you see there that there's people sitting down on little chairs and they could plug their phone in and charge it. So it's a Wi-Fi charging station. And when I think about infrastructure in the future, I wonder about whether we should be thinking about providing Wi-Fi charging or, I just lost it. What were we just talking about? That's the fiber optics. Fiber optics. I wonder about whether it should be paid for with public dollars to attract population or to attract employment to various parts of the region or wherever you are locally in order to reach those population projections that the province gives us, because we automatically think of infrastructure as water, wastewater, transportation, but really when we think about the future, there are things we're not going to, information won't be transported physically like it has been in the past. It will be through electronics. So I leave that with you as a final idea, because I think the biggest thing I want to pass on is that I think any progress that human beings have ever made in the history of time has come because someone had an idea. And then they tried it, and they, through tenacity, kept trying until they found something workable. So I challenge you all to create ideas that will help us with this really big problem, and I'm sure we will put a dent in it. Thank you.
Well, thank you, Gayle, for your very inspiring and wealth of information. Certainly your aspirational stories were fabulous. I feel inspired that we've begun the conversation here in health and planning, those conversations, and that we've just got a lot of opportunity and in moving forward. What struck me was the courage and have an idea and try it. So I think I look forward to us moving forward. So we do have an opportunity later for some question and answer that will be facilitated, but I now have the pleasure of introducing our second speaker, Dr. James Dunn. Many of us know him as Jim Dunn. Jim is a professor and chair in the Department of Health, Aging, and Society, and the director of McMaster Institute for Healthier Environments, both at McMaster University in Hamilton. He's also a scientist at the Centre for Research on Inner City Health at St. Michael's Hospital in Toronto, and holds appointments at the University of Toronto in Geography and Planning and the University of Waterloo in Planning. Dr. Dunn has extensive experience in analyzing how municipal policies and urban planning in North American cities can create or undermine the conditions for population health and health inequalities, including important markers like routine physical activity. His research program focuses on urban housing and neighborhoods and how economic and social policies can influence health inequities. Current projects include measuring the health and social impacts of redevelopment in Toronto's Regent Park and the impact of Hamilton's Neighborhood Action Strategy on health and social development. Please join me in welcoming Jim to the podium.
Well, it's been really fun to catch up with Gayle and have her give a really inspiring presentation. And I'm just going to make a few comments, really, just to build on some of the things that Gayle said and highlight, some of the experiences I had. So Gayle and I worked together starting about 5 years ago in 2010, 11. It was 2010, so 6 years ago, and on the Peel Healthy Development Index. And I think there's some really important things that Gayle mentioned, and I'm going to talk very specifically about the Peel Healthy Development Index and why it's important and what the opportunity is there. But just to reinforce a couple of the things that Gayle said, one of the things she alluded to was the idea that it's not huge changes that are actually required. And so when we think about health, most of the time things are approached from a very clinical perspective, right? So we have an approach where we say, we're going to take people at the greatest risk or who have the most severe symptoms, and we're going to identify those people, and then we're going to work really hard on them and try to change them, right? So we're going to take the people who have the highest body weights, and we're going to work really hard and try and change them. And that's an approach that makes a certain amount of intuitive sense, because it's like, we're going to focus our resources on the people at the greatest risk or with the greatest severity. But it doesn't actually appreciate the fact that those people weren't always at that high risk, and they weren't always at those severe levels, and that in fact, upstream somewhere along the way, they had lower levels of risk and had lower levels of severity. And if we had done something then, that it might actually have changed quite a bit and been a lot cheaper to do it, to be quite honest with you. And that was an approach actually developed by a man named Jeffrey Rose, who is an epidemiologist and a physician in the UK. And he wrote this incredibly influential paper in the 1980s called Sick Individuals and Sick Populations. And basically what he said is that it's important for us to think about the very routine, everyday environments that people live in, and how we might be able to alter people's routines in ways that create small changes in large numbers of people. Because the truth is, when we take those kind of clinical approaches, we can really only deliver those kinds of things to a very small number of people. And the public health impact of creating small changes in large numbers of people, so people walking an extra 5 minutes, people substituting, at even one trip a day, one short trip a day from vehicle to something that's more active, that those small changes actually add up to a much bigger public health impact than screening and treating in a very intensive way a small number of people, right? Because that is only going to be a relatively small number of people. So, and in fact, Johns Hopkins University mounted a public health fundraising campaign for their School of Public Health on this, and it was called Saving Lives Millions at a Time. And the problem, of course, is that from a kind of popular cultural standpoint, there are no shows about public health workers. Right? There's lots of shows about ER docs. We're saving, because there's nothing personalized. And the other thing, of course, is that each individual might not be getting a giant benefit, right? So if you substitute one trip a day, it's not like you're going to drop 60 pounds. It's not going to be a Biggest Loser kind of experience for you. But it might actually increase your longevity by a small number of days or months, and it may make you healthier, and it may actually forestall some of the other things that might occur with respect to using the healthcare system and so forth. I want to build on another thing that Gayle alluded to as well, and it's about the design part about this, designing it into people's routine activities so that it's not even that it's a choice, it's just what you do, right? So, and there was a new study actually that just came out in the last couple of months, and it was an evaluation of the introduction of a bike pathway in a city in the UK. And what was really interesting about it is that they talked to the people who were using this bike pathway for commuting. And what they found out is that, and they talked to them prior to the introduction of the bike pathway and again afterwards. And what they found out is that their motivation had no impact on their use of the bike pathway, and their attitudes toward physical activity had no impact on the use of the bike pathway. This is quite different than the normal logic we think about. We think about people have to be motivated. We have to change their attitudes, and then that will change their behavior. Not the case at all. It was entirely utilitarian. It's like, this is actually the easiest and fastest way for me to commute, and that's why I'm using it. It's got nothing to do with attitude or motivation, around health. So I think that those are incredibly important things, and I think that this is, again, the value of this work. So let me talk about my experience with the Peel Healthy Development Index. So I led a team that developed, I guess, the technical part, if you like, of all of the work that has now become the Peel Health Assessment Tool. There were a few things that I think that I learned out of this experience, and it was interesting because I remember when we first started, it was a very unusual project for the kind of thing that I do. So the people like me, we often do studies, and we say, and in fact I edit a journal that publishes about 185 of these studies a year. And basically it says, okay, we're going to study this problem. It's a really important problem. We have this data. We come to these conclusions, and basically at the end of the paper, there's 3 to 4 paragraphs that say, well, yeah, we were right. This is a really important problem, and somebody should really do something about it. That's it. That is the full extent of our engagement with any kind of action. And frankly, we get rewarded for that, right? I mean, if you can publish it in the best journals with the highest impact factors, we get rewarded for that. There's no, and we kind of just lob it over the fence and hope that somebody picks it up. And so when I started this project with Gayle, and they had done, in Peel, they had done an enormous amount of work beforehand, and I'll describe that in a second. I realized, this is a strange project. And I realized what we were doing was actually something called implementation research. So we were actually using the evidence that was available to create workable tools to implement the policy, rather than standing back, to use a hackneyed phrase, the ivory tower, and saying somebody should really do something about this. So what had happened prior to me getting involved is Dr. Mowat and Gayle and others had managed to convince the council that this was something that needed to be addressed, and basically they got a direction that said, we want public health to work with planning and to come up with a way to build more active communities. And they had already decided that the way they wanted to do that was through the land use development, the development approval process. So when a developer brings a proposal for a new development, that there was going to be a health component in it. And what they needed from us was something that was evidence-based, that would essentially create a score. So I remember distinctly the very first meeting that we had with Tom from planning, and he said, listen, we require a bunch of studies when a developer comes with a new proposal. For instance, sound. And we have standards for sound. And if the standard is 60 and they come in at 61, we push it back and we say, come back when it's below 60. And he said, we'd like something like that from you. And now we weren't really able to create that. It was a little more complicated than that. But nevertheless, what we did create was something that does produce a score. And the higher the score, we have confidence that the higher the score, the greater the walkability. And this has become, at the very least, a negotiation tool for the negotiation between the planners and the developers in the first instance. And over time, it's going to become probably even a little bit more toothy. And in that sense, what's happened now in Peel is that public health is hardwired into the approval processes, into routine approval processes. It's not something that requires you to persuade somebody every single time you do it. It's actually hardwired into those decision processes, and that's something that I think we need to move forward towards more. The other thing I learned a lot about in the region of Peel is that, we're sitting here in the hollowed halls of McMaster, the first place where evidence-based medicine was developed, and the idea that if we can just get the right evidence in front of the right people at the right time, they're going to go, gosh, what were we thinking? We're going to change course immediately. The truth is, the world doesn't really work that way. And I guess I'm always surprised in the evidence-based health and medicine world how unaware we are of the wisdom of the great American philosopher Homer Simpson, who has famously said, just because I don't care doesn't mean I don't understand. And so one of the things that often happens is that we try to load more information on. No. You're not persuaded by that because you don't understand yet. We're going to provide more understanding for you, more evidence. It's like, well, no, actually, the truth is when we get into these intersectoral contexts, other people, they're up to stuff. They've got jobs. And they've got missions and mandates and so forth for those jobs. They're up to things, and you're asking them to take something that's on your priority agenda and put it onto theirs. Well, what's in it for them? So I think there's a lot of work that has to be done. And Gayle is actually way too modest about her role in all this. She was, without a doubt, the spiritual leader and the motor that led to the implementation of enormous amount of accomplishments in the region of Peel. And it does take that. And it takes an appreciation of understanding where the others are coming from. And I think the other thing, too, in the health sector, we've often come in, and I got this idea from a guy named Patrick Fafard, who's probably the only person who studies public health policies, the only political scientist who studies public health policy in Canada. He's at the University of Ottawa. And he gave a keynote speech at the Ontario Public Health Convention a few years ago, and the title was, "Health is Not Special." And it's incredibly important to know that, in fact, there are other things that are being considered in these kinds of decisions. And if you want to put health into the decision-making process and into it as a priority, then you have to understand how to balance it against those other things and understand those processes. So let me just say a couple of things about where we might go in the future with this. So Peel has done an incredible job, and I think there's lots of opportunity for trying to apply the lessons that Peel has learned and some of the tools that are already available to think about active communities. But the built environment actually can affect health in lots of other ways as well. And in particular, the kinds of things that I'm interested in are how does the built environment affect mental health? And that's something that's relatively underexplored. There's a really interesting phenomenon where there's a bunch of, there's kind of a fragmentary evidence base for this. There's lots of little interesting findings that have never really been kind of rolled up into a kind of coherent framework. So for example, a colleague of mine at Cornell University, he did this really interesting work, and this was more around housing and kids. And he was working with kids aged 7 to 9, and they were living in crowded housing circumstances. And what he found is that if those kids reported that they had a place in the home where they could go to be alone, and it didn't have to be their own room, it's just that they said they had a place to go within the home where they could be alone, they were protected from attention deficits and a number of behavioral problems. And the logic behind this is that they were able to regulate social interaction. So one of the things that we know is that self-regulation is actually an important cornerstone of human development and healthy child development, and that if you don't have an environment in which you can regulate it, where you can actually withdraw from the stimulation in order to self-regulate, then you're never going to develop that capability in the first instance. And the other thing we know is that when you're overstimulated, it leads to psychological withdrawal. So this is all very well understood things, but we don't really understand how the spaces that we create in our cities and in our homes actually affect that. And it's not the case that we're always necessarily going to be able to change those spaces because there's a certain permanence to the built environment, but we can certainly work with families to understand how could you create ways to make sure that your child gets the opportunity to be alone when they really need to and to withdraw from those stimulations. So that's just one example of where mental health and the built environment might go. That actually covers my first two examples. One is about mental health, the other is about healthy child development. Let me say this from a more macro perspective. In the city of Vancouver right now, they're the canary in the coal mine for trying to understand how more dense built environments have to be adapted and to family life, for example. So in the city of Vancouver, there are now increasingly, and there will be for in perpetuity, an increasing number of families who are living in high-rise housing. It is no longer possible to live in the city of Vancouver for the majority of families in the city of Vancouver to live in ground-oriented townhouse or single-family dwellings. And so it's not to say that we can lament that all we want, but it's the reality. And the truth is now we have to think about what's the programming that needs to go and what are the design elements that need to go into the way that we build housing and build public spaces in order to ensure that we do optimize healthy child development. The last thing I want to talk about, the next step I think in this, is thinking about how our built environments might affect healthy aging. And so if we think about the projections for the GTHA, one of the biggest ones that concerns me is not only some of the commute times and so forth, but also the aging population. So right now there's about 1 million people in the GTA over the age of 80. And over the age of 80 is very important because once you reach that age, you have to demonstrate your ability to drive every 2 years. And in 25 years, there's going to be 2 million people over the age of 80 in the GTA. And what really worries me is where on earth these people are going to live. Because we have a housing system, and in the housing world they talk about people's housing careers. So we have a kind of model of the housing career where you kind of aspire and ultimately live in some kind of ground-oriented, car-dependent housing. The vast majority of the region's population do. And you cling on to that until you die. But we now have a situation where the housing system is not adapted to the longevity that we enjoy. So we can no longer have a situation where we have so many people who are in these car-dependent environments clinging on to these car-dependent single-family houses, because it's going to lead to a number of problems. First of all, many of them will lose their driver's licenses, and the front edge of the baby boom is about 68 right now, and in 12 years, we're going to start to see a rapidly escalating number of people older people without driver's licenses. And we don't have the infrastructure for it, both housing and more general infrastructure for that aging population. We have to think about how to build that now, because the lead time is only just long enough to be able to deal with the beginning of that. So what's it going to lead to? It's going to lead to an issue where there's going to be an incredible burden of care. And when we think about care, we normally think about meals and dressing and toileting. I'm not even talking about that. I'm talking about actually something even more simpler, just giving people rides. So people are going to need transportation. There's going to be an incredible burden of care just around transportation from the people who are living in these kinds of car-dependent housing environments. And that's going to be a huge issue. Social isolation is going to be also a huge issue. Social isolation has been demonstrated in numerous studies to be as great a risk factor for premature death as smoking. It's literally deadly. And so we're actually going to be in a situation where we have a built environment that is setting us up to have a huge population of people who are socially isolated, and it's going to certainly diminish their quality of life and possibly even their length of life. So yeah, there's nothing really much more I wanted to say other than to thank Gayle for coming. I was so delighted when I learned that PEDTalks had invited her, and really, you know, I can't emphasize enough just how incredibly lucky we are to have Gayle, because she has absolutely been the leading champion on this, I would say nationally, for most of the last decade, and so very delighted to see her again, and also really delighted to hear her remarks, which were inspiring once again for sure. So thanks very much for your attention, and I think that there's going to be a question period after this.
So thanks to both speakers, that was fantastic. And we do have a bit of time now for questions for either of our speakers. Comments are welcome as well. This is meant to be a dialogue. So if you want to make comments or ask questions, now's your chance. I didn't ask the first one though. I didn't take the
liberty
of the MC to ask the first one. It's going to be to Gayle. I'm curious to know how the development industry has responded to some of those guidelines you put out in terms of neighborhood design, street design. How some of the people who are building those neighborhoods and building their homes responded to those
Sure, good question. I mean, after what Jim said, I was going to say, you know, we're still quite humble. There's a long, long way to go on this work. And you know, the development industry is a private, obviously it's private sector, and they have a marketing mix, and they need to make money. That's what they're there. They're not public sector, and we have to be humble and remember that. I'll give you the short answer in a second, but the other comment I'll make is that, so I think with any of these partners that we work with, you have to be humble and understand their role, whether they are a planner or an engineer or a city councilor or a citizen or the development industry. I think that is a hugely underestimated value, because in this work you have to be able to agree to disagree sometimes, but you need to have heard each other, because it sounds Pollyanna, but there is often middle ground that can be found, but you gotta stop and listen and not start preaching as the first thing that you do in the discussion. So, so the second comment I'll make is that life is an interesting way of coming around. You know how your mother would tell you don't make enemies because you never know who you might be working for someday or working with. So I'm now working in finance, and on the plan to 2041, the focus for the Peel region is to figure out how we're going to fund the infrastructure. So the pipes that go ahead of the development, so the development can have pipes and water in the community, in the buildings that the land developers and developing builders build. So back when we were working on the Healthy Development Index, we would go to the local building association and talk with them. And now I'm back talking with them about infrastructure, and they've said, oh, we remember you. So I think that's one thing that I would say about their response, is that we were careful to listen the first time around and to try and accommodate the things that they wanted the first time around with the index, which was level playing field. Tell us what you want, don't change, because it goes into the mix of how they figure out how they're going to make money on that particular piece of property. Tell us early and ease in changes, because it's an unpredictable environment for them. They have something called absorption rate. So when they put up a high rise, they want to sell as quickly as possible, because as soon as they get somebody in there, then they're making money. If it takes a long time to sell, the absorption rate is long, that's a big problem. It's an embarrassment when the metrics go up at the meetings where the VPs, have to show what they've done. So I think that we've listened and learned a lot about the environment that the development industry lives in, and tried to understand what they need to be successful. So that's one comment, is listen and try and figure out how to get your two agendas to come together. And sometimes it's as simple as saying, we want it to look like this, can you do it? The second comment I make is, I was telling Jim this story before we started, that I think you just have to not give up, because sometimes no, we can't do that doesn't mean no, we can't do it. It means I don't know how you're going to do that. And I have had actually that answer from an engineer once, and then from a prominent developer when we were showing them the active design guidelines for affordable housing, and I said I want the garages, I want a space in between the townhouses where kids can play, people can grow a little bit of garden, and it's communal space. And they said, well, you can't do that because we'll have to put the garages on the back. Well, put the garages on the back, that'd be great. But it wasn't in the marketing mix, and it was an absolutely crazy idea. And this was a conversation at senior management level. But what was good about it is by creating decent rapport and being earnest and tenacious, we managed to get the agreement that they could go back, rework it, put the garages in the back, and that was the building that I showed you where there was the plants in between the two townhouses. So one, you gotta be humble and listen and understand you're not gonna get everything. They have to make money. That's what their business is. And two, it's helpful to try and have a bit of meeting of the minds to see if there's and no doesn't always mean no, if you can explain what you need, what it needs to look like so that they can make adjustments.
Thank you for your interesting ideas. I noticed that you used the example of a Hamilton LRT, and I think you assume that it's a complete go-ahead.
Well, only because my son said, oh, can I use that for school next year, Mom? And I went, no. So I know it's not in the bag, but you're further ahead than Brampton.
So this week, when one councillor tried to put everyone's feet to the fire to confirm it, I wasn't quite sure. But my question is about using your tools around the subject of Hamilton's hopeful LRT. I've never seen any data in Hamilton using this sort of tool to support the value of this for better health. Could we just, if we wanted to, just use the broad generalizations?
My short answer, and I'll let Jim jump in because he's the designer. It's not as easy to defend at OMB, the Intermunicipal Board, if you don't have the scientific evidence. That's why we spent such time, put such care into thinking with researchers about how to be as scientific as possible. And the health index I mentioned is for land use policy as opposed to transportation. But can you use the broad principles? I mean, I think there's that point I made about aspirations, that no one wants to be part of decision-making to create something that is not going to be valued. So I do think there's a point to be made related to aspiration. And then the other place I would go is looking at other cities that have done it. That was very helpful for us when we brought New York City or people from Montreal or Vancouver to meet with their peers in planning and transportation, or planning, transportation, and counselors, so that they could hear how they made it through the tough times. Because this, it's fun to talk about this work, but there is real pain in the transition and real cost. So you can't ignore that, but you can also be defeated by it. So I would say yes, but I would add in profits from another land and aspiration to help.
I would only add that, I think there is a great opportunity to leverage mass transit investments for a public health impact, precisely because what's going to happen is that within a small radius, and usually it's about 800 meters is kind of the given idea that people will walk to a transit stop that's going to go that fast. They'll walk as far as 800 meters. That we can provide that opportunity to a much greater proportion of the population. And a lot of research has shown, in fact, Peel commissioned such research, has shown that there's actually an incredible undersupply of walkable communities. That there's, if you, basically on 7 different dimensions of what makes a walkable community, if you ask people, what kind of neighborhood do you live in now on those 7 dimensions, and what kind of neighborhood would you really like to live in, as much as a third of the population is actually misclassified and would actually prefer to live in a much more walkable environment than they currently do. But there's a lack of supply. And so there's certainly some decent evidence of that. And I would say that, going forward, the way we can kind of leverage this for public health impact is to be able to give more people the opportunity to live in those kinds of environments where they can be more active. And one of the big ways is to be able to have those rapid transit investments.
There's a woman who put her hand up down there, and then we can go to Mark, and then there's 2 others. So yes, you first. No, yeah.
I'm interested in racism concerns that affect essentially a quarter of Hamilton's population. I'm speaking of a group that at 19% of their addresses in the realm of poverty, in low income, those with disabilities, those with mental health issues. We're talking 25% of the population. We're
Yeah, okay. So I'll give it a try, but thank you very much for your question and for bringing that up. At one point when I was working in this, I used to say to my staff, okay, I'm sufficiently depressed now. This is just too difficult a problem, because you no sooner get one issue solved, and then as you widen the lens, as you've done, you can see a host of other issues. But I do think you need to start and carry on. So on that theme that it's odd how life turns out and you end up in situations you never dreamed you'd be in. So I found myself the acting commissioner of human services. Our affordable housing program is in it a few months ago while they were recruiting a full-time person, and we had this exact issue, is that we are trying to help the cities have an affordable transit system, but it's very difficult to run an affordable transit system, both for the city and for citizens in a subdivision. It's just horrendous. You need a grid pattern like you have here in Hamilton in some areas, but we're a very different community in Peel. So we knew we needed to support them. So we created a program where the individuals on social assistance, so they're not working poor, pilot using it. So then we expanded it just recently to low-income individuals, and that was a tough discussion because the region had to decide, are we going to provide the transit fare? The administration is, in effect, we're now subsidizing the city's transit system. So I do think there's creative things that you can do when you think about the various pockets of people it are to affect. And just the part that's making me feel a bit daunted was your point about how there is less space and there's design issues. On CBC Radio recently, I heard, I think it was in Calgary, that a very wise planner there was having a discussion with the ambulance and the fire folks to try to get the trucks to be a smaller size so that they can plan space for the bike lanes and the city streets. So I think we just have to be patient with this issue and not, be too doom and gloom, because it's always going to, by making one change in this house of cards, we trigger other problems. And it's not like the fire and the truck people, or the fire and the ambulance just want to be difficult. They just want the biggest possible space to do what they're going to do. But that does cause problems for snow removal and the design of cities. So I think we have to take a deep breath and realize we're in this together. We will transition over time, but there's going to be some ups and downs. But thank you for your question for that group.
Just maybe a quick comment and then a question. I am an engineer, and an apology is just an explanation of how we think. Engineers are hired and trained to solve problems. They're not necessarily trained or asked to define the problem to be solved. So I'm wondering how, when we think about the problem, as you pointed out, it's a healthcare issue. I completely agree, and a fantastic presentation. Being humble is great, but sometimes framing it as actually bad design makes you sick, and bad design kills you.
Yeah.
And the calling of an engineer is not unlike a doctor in some respects, that our calling is to do no harm. And I'm wondering if you can talk to the PEO, professional engineers, I'm sure, with groups of that nature, because it has to be addressed right into the teaching, that bad design is our responsibility. It's our accountability. And designing a road, maybe it goes 60 kilometers an hour one way in a city, on a sidewalk, beside a sidewalk where you're expecting a child or a senior to walk beside, is just bad design. And so I'm just wondering
Great question, and there's so many responses. But my
Question
son's,
still.
the question.
Oh,
that was Selena.
engineer.
Ready?
The question is, and it goes back to what you were saying in terms of why should we care? It's like any product, you can go up with great ideas, but who cares and why would they care? Why would anybody, quote, buy this product of healthy communities? And you look at, so where is the maybe discontinuity? And maybe the question, I don't know the answer, but when you look at the framing
sounds rather complex, but what people do understand is dollars. And what's really interesting is that when we show that chart, 49% of our budget doesn't go to healthcare, actually goes to illness care. And that's a very huge chunk that you say, if you're trying to reduce our taxability, if you're trying to reallocate things, that would be the first thing to go after. But part of the problem might be is that where the savings occurs is not where the decisions are being made, and where the savings can actually be allocated. And I'm wondering if you've had any conversation, or appeal or otherwise, because when we talk about our city needing $25, $30 million to do a proper bike network, we're saying we can't afford it, and things of that nature. But if we're actually saving lives, we're actually making people healthier, they live longer, we save that up to $4.5 billion. If some of that was actually allocated back to the community, where good decisions were being made, or rewarded in that community, maybe we had a better impact on it earlier on the kind of design this one.
Well, I think giving a good answer to the question is if the savings went back. And at one point in my career during the, what I call the dark ages in the 90s, when people were being laid off left, right, and center, and you couldn't get funding for anything, and you'd get sent away always to find 10, 15, and 20% for your budget. So I can remember going to the staff and saying, okay, whoever finds the savings, you get to keep half, and we'll just cobble it all together to try and motivate people. So I think the answer to the question is that it would be an interesting design change to say, if you're applying for infrastructure funding, federal or provincial, you have to show the healthcare savings, you have to work with public health, so make it a requirement. And I actually had that idea left over from when tobacco bylaws were coming in, some early work that public health did in the 90s, and I can remember Cancer Care Ontario in Mississauga said, Mississauga site said, you have to be smoke-free. They weren't smoke-free. It seems crazy now, but at the time they weren't. So I do think there's an interesting health in all policy, or thinking across policy work that can be done to better link who's getting the reward for where the decision made. Because that was one of our early struggles with municipal councillors. They say, well, I don't want to save money for the province. I want to save money for our budget. I don't care. I hear what you're saying, Gayle, but it doesn't help. So I think there's some interesting changes you can make. We certainly see that in grant applications now. Having heard Jim's story about having to work with health professionals and practitioners, we're not quite as hard-nosed researchers as you might want us to be, because we live a practical life. But a lot of grants now require that there be a researcher, practitioner, policy triad. And then, you answered the question. It would be interesting to make infrastructure applications for funding conditional on showing the healthcare benefit, even if it doesn't go back, but it's showing how you can quantify it. The only other comment I'll make is that I have a lot of respect for engineers, and I have some becoming one now, so you have much choice, but I do have an internal respect for your ability to think through problems, and I do think there's a strategic role that the engineering community is starting to play. No, I haven't presented to that group, but I certainly spent a lot of time with the Transportation Association of Canada engineers talking about how there's a future within their field, I think, for engineers to be providing a strategic consultative advice along with the technical, but at the tables where the decisions are being made with planners and with policy folks, because you understand how it's going to work underground. And it was a huge insight to me that this document needed to be produced so that our engineers could create bike lanes.
I'll just add one small thing, which is to your point, to say that, people will say, oh, that may save money for the province, but it's not going to save money for me. One tricky part about healthcare is it's hard to actually get that money out of healthcare, because healthcare costs are actually far more supply-driven than they are demand-driven. So, basically, because there's a whole industry that's always developing new tests and new procedures and so on and so forth. So that's a large part of the cost, and they're already operating at, in excess of full capacity. So it's very hard to get that money out in any kind of practical sense. And then I would say that in terms of the multi-jurisdictional thing, there's lots of things that I think we could say that would make a direct difference to the things that our local community would benefit from. So more intensive use of infrastructure, and Pamela Blay actually has laid this out in incredibly fine detail about the costs of suburban sprawl, right? And it's incredibly expensive. And that more intensive use of putting more of the built form into the already built up areas, which is what the provincial growth strategy has now intensified in the last couple of days, is actually going to save us all money. So I think that in that sense, there's a direct link and that we can make, and that might even be more powerful. So there's multiple angles at this, and there's probably not just one that's going to be persuasive. And while the healthcare one, I think, is persuasive to some, it might not be to others, and so I think we're going to have multiple approaches.
A couple more questions, yes.
about. Unfortunately, Dr. Dunn, when you say that no big changes are needed, there is a really, really big change in Hamilton, and that's area rating as it applies to transit. Because we're not going to crack the nut of providing public transportation unless we don't have area rating. And I mean, every person in this room has to understand that, and you have to go back to your counselors and explain, because you see the suburbs, they don't want, they're saying, you know, they're refusing to pay for transportation. And so, of course, someone living in Bimbrook doesn't have access to transportation because they're, you know, it's all localized into Bimbrook, it's localized into Ancaster, and, you know, so on. So, unfortunately, you know, it's all, this is the big change that needs to be done. And I would just like to ask Jason Thorne whether, building on what Dr. Dunn said, which is exactly true, that the developments of the Crescent by Crescent streets are killing the older adults. And I'm wondering, has your department taken a stand on that, and are you still allowing Crescent Street developments to develop? And if you are, I agree with this man, you know, do no harm. I mean, by accepting Crescent Street development, you are actually doing harm, outlined by Dr. Dunn.
So I'm going to try and help everybody out with a quick comment, because I learned about area rating from my friends in finance. So Bill 73 requires area rating to be considered now, instead of getting development charge application across homogeneously charged to a specific area. But what I'm learning is it's not as simple as it sounds, in that you have to be really accurate as you estimate what the cost
No,
will be.
excuse me, that's not, that hasn't, no,
No,
area
you're talking about
rating
something
has nothing to do, in Hamilton, has nothing to do with development charges. No, area rating in Hamilton only means that the transit, the HSR, is only funded by the original Hamilton City, and
Okay,
it's
not
not
different.
funded by the other suburbs.
Okay, so the comment I'd make on that topic is, and it links to do no harm, is I think, as I was saying earlier, we all have to realize we are in this together, and it is, these are public issues, these are policy issues, and we do have to think I think, I mean, you could disagree with me, I think in a global way, because, for example, when you said do no harm, the engineer gentleman, I was thinking about a death we had on Steeles where a truck hit a cyclist who, in his country of origin, cycling would be completely normal, and the trucker didn't even know he hit him because it's Steeles. It's a huge 4-lane arterial road, and then later the gentleman died. So he was charged, and I think we, as the folks that put those roads in, have some accountability. But nobody intended anything to go the way it went. But I do think now that it's happened, we do need to come up to the plate and think together about how to create a safer space there. And I'll leave it at that. Jason wants to jump in.
I'll quickly respond to the second question, and then I've got this gentleman's question, and then Councillor Pearson had a question. So on the street design, so I think we're seeing a lot more grid design in some of the newer neighborhoods. It's not exclusively grid design. Typically, the kinds of questions that we look at are walkability to transit stops. So what is your actually direct walking route to a transit stop? What are those walking distances? We have now council just adopted new engineering guidelines a couple of weeks ago that are going to require on both sides of all streets in all situations. So that's going to be new for Hamilton, which hasn't always been the case. But I think some of those questions, some of what we've been hearing today, there's a lot of why planning department and public health department are kind of going through a process right now, seeing how we can sort of better fuse together those two functions and services. So, bit of a short answer. So I want to get to a couple more questions. So this gentleman's had his hand up for a while, and then I'll go to Councillor Pearson.
Okay, thank you. You mentioned how important it was for children to walk to school, and particularly elementary school children. Well, I'm sad to say that in Hamilton, we're going exactly the opposite direction. We're closing small local elementary schools and creating very high capacity elementary schools that in some cases ask students to walk as much as 6 kilometers, which is almost impossible for a 6-year-old child. That is being done because the local Board of Education is driven by the funding formula, which says, here's the way you have to build your schools, and therefore we're doing the exact reverse of what you're advocating. So I guess my questions are these. One is there an optimal walking distance for elementary school students? Is that distance recognized? And what is the chances of getting the Ministry of Education to adopt that in their guidelines for school placement and school closure?
Good questions. I'm going to leave the first two because I don't know the answer.
And I know the Ministry of Education is not here.
1.6. In terms of the chances, I think and to take you back to my point about it, sometimes I do feel overwhelmed by this issue because you trigger so many other questions at so many levels. So, and I sympathize. That's my answer. In Peel, my children could go to any of the 250 schools. So there are buses that come into our subdivision that are publicly paid for by the public board, by the Catholic board, by the French board, by parents who come together and buy a bus to send their child to any of the schools. It's a crazy policy. The schools do it because of the provincial policies related to funding, but it creates this incredible amount of traffic every day across 1.3 million people, 225,000 children not going to their local school that they could walk to because of the way cities designed for the most part in Ontario they're there within walking distance. But I'm embarrassed to say both sons wanted to go to a different high school and we paid for a bus to pick them up in addition to the publicly funded bus and send them to those schools. So I think, I repeat, I am overwhelmed by this issue at times. We are all in it together, and we do need to keep asking the questions you're asking to figure out how all of the policies work in sync. Because you can't blame the school boards for trying to compete. They're paid by the head, number of kids they get in the door. Do you want to try the optimal distance one?
I don't know.
Yeah, I don't know the answer to that question.
One of our audience members has the answer.
It's 1.6.
1.6.
1.6 kilometers apparently is the answer. And we're currently asking our students to walk 6. So there's a big gap.
Sorry, I had to
And
put this
the Ministry of Education is impervious to suggestions, as far as I can see.
When I grew up, it was a mile.
Yeah, a mile.
Got a crowdsource of the wisdom here.
Thank you, good evening, and as Councilor Person Warren has to agree.
Thank you for
I have a question, but I also have a comment to previous speaker with regards to area rating on transit. I want to clear the air now that suburban councillors' wards, we do pay area rating transit, and we contribute to the system to HSR in Hamilton. We don't pay at the same level as Hamilton because we don't get the same service. So I just want to clear the air on that. It is paid, not at the same level. Okay, I just want to clear it. And I want to go on the record now so residents understand. I have fought with my staff in HSR since 2003 to get increased service in my ward. And unless I have butts in the seats, as we call it, and the development growth, unfortunately it's a formula, I can't get that transit. And if I can't get the transit, we don't pay more. So I just want to clear the air on that. I do have a question though, because Dr. Dunn, you just raised a valid point when you were speaking earlier about LRT and the great benefits of it. And yes, we're addressing it right now in Hamilton. But you raised an issue with the aging population. And I have a concern because that was one of the points that was raised when I had the presentation with staff on our LRT and how it's going to be designed to the city of Hamilton. Obviously, the stops are going to be expanded, so it'll be a much greater distance. How do you see that affecting the population who is aging and being able to access a system that we're hoping will draw the seniors and the citizens of Hamilton into?
Well, I think that actually there are many benefits to LRT in terms of from an accessibility standpoint. One of the key ones being that it's designed to be accessible, right? It's level, the floor of the vehicle is at the same level as the platform, and it's entering to the station, so you don't have the hurrying, right? So a lot of accidents will occur because somebody's trying to hurry to get onto the bus, they don't delay it, and that's not happening because in fact people pay their fare to get into the station, and so that transaction is taking place prior to the arrival of the vehicle, and then once the vehicle arrives, this is part of what makes it rapid, once the vehicle arrives, then everybody enters and exits, and that's the only thing that happens, right? There's no payment transaction that's taking place. And the other thing one of the other things that makes it rapid, of course, is that there's no climbing the stairs or descending the stairs. So all those things are beneficial for older people, to an immense degree. And I guess I would say that also it's going to be incredibly beneficial for the distance that can be traveled in a relatively short period of time, and it's going to be considered an amenity. So there are going to be people. Not if this is, when I say I'm promoting, more dense environments and that we need to have a greater proportion of our older people living in those kinds of environments in order to allow them to live independently for longer periods of time. It's not going to be for everybody. It's not going to be everybody's choice, but it's currently grossly undersupplied. There's good evidence to say that there's a large demand for those kinds of environments. And as a result, people will do that. And what they'll do is travel between nodes. So it's not a matter of traveling, that you need to necessarily to be able to reach every business, for example, on King Street between two stations. You need to get from node to node. And those nodes will be concentrations of services and activities and other residences where the people are visiting and so forth. And that will be the nature of the transportation. And so that, I think, is kind of the vision that we're working towards. And so by no means, I think, will it be, it would be different. I know that in other cities where there's rapid bus systems, there's also a small amount of local bus that does make stops between the major stops. And I'm not sure exactly what the plan is for that, but that would be a good way of augmenting it if that became a concern. But ultimately, the idea here is that there is a fair bit of, if we go back to the way that the world, the disability world thinks about things, disability is partly about functioning and partly about environment. And if we alter people's environments, we actually reduce disability. And we can do that on an urban form. So I think that as a region, the GTHA, we need to think about how we can accommodate that extra million people over 80. How can we build entire neighborhoods so that they're age optimized rather than just age friendly? What kind of built form do we need for that? So probably it means dense opportunities for public transit. It's going to mean different set of services that are happening at ground level. It might mean enhanced snow removal. It might mean different kind of policing. And the other thing too is that we've got, the industry in the aging world is certainly picking up on this because they're expanding from long-term care and retirement homes into affordable apartments. But that's a very, very specific taste that the Revere's and the Schlegels of the world are providing in terms of assisted apartments. And it's also very unattainable for most people in terms of the cost. But not everybody wants to live in a completely segregated age-only community. Many people actually quite like to live in mixed age communities. And it turns out that it's actually millennials who are demanding the exact same kinds of things that we need for our older population as well. So those are some of the things that I think I'm seeing emerging as trends in the literature.
I think this is the last question right here.
In Hamilton, we have a situation that's probably not unique. You see it in Toronto where it's the suburbs versus the city. And therefore, sort of occurs that kind of thing as well. In Hamilton,
I have to bring that up.
Oh, sorry.
We're just getting over it.
Okay. In Hamilton, I think it's worse because we have actual geographical escarpment, to the mountain and versus the city. And it seems like, and with all due respect, I'm not referring to the councillor in the room, but some councillors are very parochial and provincial, and they feel that any improvements made in the city are at the expense of the mountain, sort of a zero-sum game, which I think is silly because I think that anything that benefits the city, whether you put a bike lanes in the core or rapid transit, it benefits everybody, even on the mountain. You have reduced car traffic, reduced air congestion. You have, people don't talk about the economic development that transit is improving to spur along those nodes, so you get condos and apartments and offices and all kinds of development. And that brings in more revenue, which will hopefully alleviate the tax bill on everybody in the city. So how do you convince people in the burbs that what's good for the city is actually good for everybody? Because if somebody said you can't be a suburb of nothing, that's not my quote, and somebody else said that.
That seemed to embrace.
Oh, I can talk about
Okay,
this.
go for it.
I didn't
Well-
I mean, it's frustrating.
So let's compare it to the United States. So in the United States, there's a very strong tendency towards a high level of municipal fragmentation. So Greater Minneapolis has 187 different municipalities, all within the metro area. General purpose governments, right? They also have lots of special purpose governments like water districts and all that. And this is absolutely incredibly inefficient. It's also incredibly inequitable, because what you end up with are little mini municipalities who are essentially competing to bring in people bring in a high tax base, who have low social needs, who get relatively good services at a relatively low cost. And then you have all these other things. And it actually perpetuates all the inequalities that many of us are, or many of us that were profiled in the Code Red report. We are actually in a unique situation in Ontario due to amalgamation. You can say what you want, whether you like it or you don't like it, but I can tell you without question that amalgamation has been beneficial in terms of the equity of our society. It has made our cities more just, in the sense that we share the same tax pool, that the services we actually have to assign based on need within that same shared tax pool. And there is a high degree of dependency between the people who commute to the central city. And that central city, as you said, you can't be a suburb of nothing. What you have in this situation in the US is you have a lot of free riders, people who pay their taxes where you sleep, right? But people who commute to the central city, they use the police and the fire and public health and all the services that happen in this town. We're not in that situation. We're in a situation where we actually have a shared tax base and we assign things according to need. But the thing is that we don't recognize, I think, exactly what you're suggesting is the economic base. Downtown Hamilton is the home of 25,000 jobs. There's actually a huge amount of vacant office space that's increasingly going to be filled up as there's more and more development, and it's going to be more and more jobs. And the truth is that that's the economic engine of the city. This is the central city, and that will continue to be the case. And so I think it's unfortunate that some of those things get played out that way. But we're actually in a far more advantageous position than many of the municipalities in the U.S. And I mean, I lived in the U.S. for a year in 2011. And in addition to all that kind of segregation, there's also school district segregation and incredible inequity created by that. And I actually think there's very little hope for the U.S. because of those kinds of inequities. And we're in a fortunate position, and I think that we're quite a bit further ahead because of the structure of that kind of governance. But on the other hand, it's really unfortunate that it gets, dragged out in ways that